Okay, so good afternoon, good evening, good morning. Welcome to another webinar series on the complete wellness. And shout out to the Animal Health team, the Virgin Medical City. My name is Francisca Usage, your hosting physician. And it is a pleasure, as always, to have you here. And today we're going to be talking about something of utmost importance to, should I say, the female community. However, not just the female community, but the males in our lives, the husbands, the sons, the brothers, the cousins. We're going to be talking about ovarian cancer. Now, ovarian cancer is the second most common gynecological cancer. However, the deadliest cancer. And here I got some stats, like always. According to the American Cancer Society, about 19,710 women will receive a new diagnosis of ovarian cancer. About 13,270 will die from ovarian cancer, and that is for 2023. Now, ovarian cancer ranks fifth in cancer deaths among women, accounting for more deaths than any other cancer of the female reproductive system. So we can see the importance of that. And because of that importance, we actually have a very prominent authority to help us unravel the questions around ovarian cancer. Welcome our guest speaker, Dr. Abu Jafaru. Dr. Abu Jafaru is a very distinguished and he has a highly acclaimed medical persona, having merit awards from various societies, including the societies of Royal Societies of Medicine, Obstetrics and Gynecology in various international communities, including the UK and the Caribbean. Now, he is an avid mentor and what I would consider the consultants, having established the annual Nottingham Advanced Laparoscopic Training Course for the gynecological consultants in UK, in which consultants and senior trainees acquire the skills necessary to successfully perform complex laparoscopic surgeries, that's gynecological laparoscopic surgeries. He's also experienced, having 3 decades of experiences in the specialties of obstetrics and gynecology, and also highly specialized area of surgery, that's gynecological oncology. He is currently affiliated with the Virgin Medical City, however, has held senior positions at the University Hospital of Leicester, the Nottingham University Hospital in UK, the Royal Brisbane College, the Royal Brisbane Hospital of Sydney, I think that's it. And then I also would mention his affiliation with University of Benin, which is where he earned his medical degree. And pardon me on that, because that is where I personally obtained my medical degree. So there's that bias, and very proud of that achievement. Now, need I also mention he's a member of societies, various societies, including the British Royal Society of Obstetricians and Gynecologists, the European Society of Gynecological Oncologists, the British Society of Colposcopy and Cervical Pathology, British and Irish Society of Robotic Gynecologists. And could actually mention that, write a book on the various, memberships. But I think I should end here. And please help me to welcome Dr. Abu Jafaru. Thank you so much for honoring this invite, Dr. Abu Jafaru.
Thank you so much. It's flattering. It is my honor and privilege to be invited to your platform to answer questions relating to ovarian cancer, which you have beautifully introduced.
Yes, thank you so much. Okay, so let's go on to start unraveling these questions. So at the beginning, I just mentioned here in the US, the statistics, you can see there's a high number of cases reported annually and deaths, as a matter of fact. So can you help us appreciate, I know you are in Dubai, can you help us appreciate the prevalence in your environment and probably even just worldwide? How prevalent is this condition of ovarian cancer?
Now, like you said, in the US, it's a deadly disease. Now, ovarian cancer worldwide is the eighth most common cancer in women in the world, and it is the 18th most common cancer overall. And if you look, you talked just now that the incidence in America is about 19,000, you said. But if you look at the worldwide incidence, it is over 300,000 cases every year. And the mortality from ovarian cancer, like you also said, if you put the mortality from ovarian cancer alone, it actually outnumbers the mortality from all the other gynecological cancers put together. And the annual deaths from ovarian cancer worldwide is over 200,000. Now, you have an online database called GlobalCan that provides what you call global cancer statistics, such as incidence, mortality rates, as well as they're able to project into the future based on the past trends of statistics. And GlobalCan actually projects that by 2040, which is only just about 15 years from now, that the incidence of ovarian cancer will go up by about 40%, and that is almost about 450,000 cases every year. And that the annual death rate will also rise by about 50%, and that will be well over 300,000 every year. So it just tells you, you cannot take this cancer for granted. We need to fight it, very, very aggressively.
Wow. So is there any causal factor they are attributing to the rise in the incidence? They're projecting, is there, I mean, what is going to cause this rise in incidence? As
I think it's all partly because we are all living longer now. So you're going to have, because ovarian cancer itself is usually with a disease of older people. It doesn't mean that people who are young cannot develop ovarian cancer, but it's usually a disease of older people. We are living longer, and also there are certain factors that will increase the incidence of ovarian cancer. For instance, being overweight or people who are obese, that can increase the incidence of ovarian cancer. Another thing, again, is that women in general are delaying when they're going to have children. They're postponing when they're going to have children to much, much later years. And that means that you may end up actually having some women not having children at all. And we know that infertility and infertility treatment, all these are factors that can increase the risk of developing ovarian cancer.
Yes, wow. That is interesting to note, actually. Really attributing that factor, which is really a trend now. Most of us women, well, we want to better our education, probably suspending that, wanting to have children, and then there's also the fact that, okay, when we decide to, or when, the typical case of having had that education, you now want to start the, family, probably get to your late 30s, early 40s, that might, that is a trend that really wasn't the case maybe 20, 30, 40 years ago, right?
Absolutely, because people want to pay more emphasis to their careers, rightly or wrongly. And we know fertility is usually better the younger you are. Once you're hitting the age of 35 and 40, fertility decreases. And those are the women that will require fertility treatment. And that is one situation that can increase the risk of developing ovarian cancer.
Yes. Thank you so much for that. So you talked about it presenting towards the later age in a female. Can you tell us that typical range of age of presentation of these females? What's that typical age they do present with ovarian cancer?
Usually above the age of 50. Majority will come above the age of 55, 60. But that does not mean you cannot have younger women who could develop ovarian cancer. The youngest youngest of my patients that I treated with advanced ovarian cancer back in the UK was only about 15 years, was only about 15 years old. Okay. But typically, it's usually a disease of older women above the age of 50.
Okay. So typically, it's the disease condition affecting typically ages 50 and above or female. Now, a question I would ask is, just like we have, different kinds of breast cancer, variants of breast cancers. You did mention just now, a female of 15 presenting with ovarian cancer. Do we have variants too of ovarian cancer? Is it the same kind of cancer that affects a 50-year-old? That's ovarian cancer that's going to affect 15. Even amongst the 50s and over, is there a variant of ovarian cancer, or is just this kind of ovarian cancer and this is it, just one prototype?
That's a very good question. Actually, they're different. In the majority of cases, they're quite different. Now, if you look at the ovary, if you consider the ovary, for instance, like a shell, it has an outer covering we call the epithelium. And then we know the function of the ovary is to produce egg. And you have the egg producing part of the ovary. And then you have the connective tissue element that hold all these eggs together. And that's what we call the stroma. Now, the epithelia type of ovarian cancer is the one that tends to affect women who are older. And that accounts for over 80-85% of the majority of all types of ovarian cancer. Now, the stroma and the egg-producing type of ovarian cancer, we call the stroma ovarian tumor or the germ cell ovarian tumor. These are usually diseases of the younger women below the age of 40.
Okay, and these variants of cancers, do they have the same kind of presentation typically?
Essentially, yes, they have the same kind of presentation. Obviously, when you have a younger woman presenting with cancer, especially if they've not had children, then you are thinking about how are you going to treat them such that they can preserve their fertility. Obviously, they're presenting much later, then you don't have to worry so much about fertility preservation. The majority of women presenting with ovarian cancer will present with abdominal bloating and abdominal distension.
Okay, thank you so much. So if you're just joining us, we have Dr. Abu Jafaru, a specialist, he's an obstetrician and gynecologist and a gynecological oncologist, discussing the topic ovarian cancer. So far, he's mentioned the high prevalence of ovarian cancer worldwide, including the very high mortality associated with ovarian cancer. It happens to, it's not the commonest. Over here, I did mention it in the US is the second most commonest. However, it's the deadliest. Combining all gynecological cancers combined, this presents with the deadliest cancer. he also mentioned the typical presentation for ovarian cancer is with older, ladies above ages 50, typically. However, it is not unusual because he has had a patient in her 50 who was a teenager presenting with ovarian cancer at the age 15. And there are variants of ovarian cancer. There is, if you look at the anatomy, you just briefly mentioned the anatomy of the ovaries. You know, you have the outer lining, the epithelium, but within the ovaries, you have what you call the stromas producing eggs, you know, and so the cancers can affect both the epithelial tissue itself and even the stroma. And there's what you call the germ cell tumor, typically affecting the younger female. So that is just a quick summary. So we've talked about these, Dr. Abu. Can you mention the causes of ovarian cancer? I just remembered you talked about the presentation of bloating, abdominal distension. Sorry, at times my mind works that way. But now let's talk about the causes of ovarian cancer. Is there like a known cause? I know there's a predisposing factor, but is there like a known cause for ovarian cancer?
Yeah, you're absolutely right when you say there are predisposing causes to ovarian cancer. Unfortunately, the vast majority of cases of ovarian cancer that we see are sporadic. And these are patients who do not have any genetic link at all. They live a very healthy life, and they will tell you, doctor, I have never, ever been to the hospital. So the vast majority of cases are sporadic, but there are predisposing factors. We say factors that will increase the risk of ovarian cancer, being overweight or obesity is one of them. And then, of course, there is the genetic factors. And then you have women who have never had children. We call that nulliparous women, or infertile women, or women who have had infertility treatment. Now, unfortunately, if you have, if your period was to start very early, we call it early menarche, say below the age of 12, you also tend to have late menopause. So if you're having very early onset of your periods and late cessation of periods, that gives you so many years of ovulating, and that can cause repeated damage to the epithelium of the ovary, and that could increase the risk. And also smoking can also cause, it's a risk factor for developing ovarian cancer.
Wow, that's interesting to note. So what Dr. Abu is saying, for females that have that do start their periods early and that have had that extended length of having periods repeatedly towards a late cessation of periods, which is what we call the menstrual cycle, as the menopause, that extensive length actually is a predisposing factor or predisposing risk to ovarian cancer. He also talked about and you did mention this earlier, the weight, obese ladies being at risk, right? And also smoking. Okay, so now that we've looked at the presentation, the predisposing factors, let's talk about the management. Let's understand the management. How is it typically managed? How do we manage? Have we made that? Okay, maybe we should start with how do we make the diagnosis? And
yes. As a doctor, usually what patients will present with is abdominal bloating, abdominal distension. So these are generally the symptoms that they'll present with, and they may present with needing to urinate so frequently, very occasionally with constipation and even indigestion. So you can see that all the symptoms I have mentioned, they're actually very non-specific, really vague symptoms. And this is one of the reasons that the majority of cases of ovarian cancer, and in fact, unfortunately, over 75% of ovarian cancer cases that we come across, they present at a very late stage. And the diagnosis is based on the symptomatology, clinical examination, and then ultrasound scan, and then the simple blood test we call CA125 blood test. Now, just to quickly mention as well, you will hear the old saying that ovarian cancer is a silent killer. I personally does not believe ovarian cancer is a silent killer. I think we as physicians need to be trained to identify the symptoms of ovarian cancer. Like I said just now, they're really non-specific symptoms. So you need to have a very high index of suspicion. If you suddenly have a postmenopausal woman coming in and saying, "Oh, doctor, I feel my clothes are tighter, I feel abdominal bloating, and I eat small amount of meals and I feel full," that should begin to raise alarm bells that could this be, early onset of ovarian cancer? And can I do more investigations to hopefully catch it at a very early stage?
Well, what you just mentioned, I would say, if I'm a typical person, not in the medical community, I'm getting older, we tend to put on weight. Obviously, with putting on weight, our clothes become tighter, right? And bloating at times is a symptom a lot of people overlook because, gosh, you're getting old, your system is not as, functioning. So is that one key thing that should, prompt a person that maybe I should just present to the clinic because yes, I'm getting old, I'm putting on weight, so my clothes are getting tighter, I'm feeling bloated. Is that one symptom that should actually alert the patient or the person to go see the doctor just to rule out, this being a cancer, talk less ovarian cancer?
Do you actually know the funniest thing is that so many women who have ovarian cancer, they actually do present early to their doctors. Mm-hmm. And it's just we as physicians, we ignore the symptoms that they present to us. I've been a consultant in gynecological oncology for almost 18 years. And so many of the women I have seen with advanced ovarian cancer, they come to me in the consulting room. They'll say, "Doctor, do you know I have been seeing my primary physician for the last 6 to 9 months? And I have told them that I noticed that my clothes are tighter and I'm feeling full." And they just tell me, "Oh, it's because of the menopause. That's why you put on weight." So I think the patients are actually presenting. Women are very good when they notice any alteration in their body habitus to present very early, unlike men who wait until they're almost close to dying before they actually go to their doctors.
Yeah. So, as you mentioned this, what comes to my mind? I mean, we have a way of screening for ovarian cancer, but it doesn't seem to be, religiously done like we have like the breast screening and all that stuff. Except there's a high index of suspicion, So why do you think that is?
Well, there have actually been quite big randomized controlled trial. That was the UKC Talks trial in the UK, which was a multinational big trial that recruited tens of thousands of women across the globe. Unfortunately, unlike cervical cancer, breast cancer, there is no effective screening method for ovarian cancer at all. So that is the dilemma that we see faced with ovarian cancer. So we have to rely on the symptoms, even in patients who are high risk, who have genetic factors that predisposes them to developing ovarian cancer. We still don't have effective way of screening them. You can do annual pelvic examination, ultrasound scan, CA125 level. Yes, it may pick you up, but it's not very, very sensitive at all.
That's interesting. So with this, what is that typical, at what stage is this ovarian cancer diagnosis typically made? Because like you said, most times women are, doing what they should, go see their primary care, and yet that diagnosis is not made. So when does it now alert the primary care that this might just be a case of cancer before the referral is made? And so what stage do you typically catch this? Most of these females, what stage do you see them presenting?
Like I said before, cancer generally is staged into 4 stages. You have stages 1, 2, 3, and 4. And within those stages, you have sub-stages like stages 1A, 1B, 1C. And then you have stage 2A, 2B, 2C, and 3, and so on and so forth. Unfortunately, over 70% of patients with ovarian cancer will present at a later stage. And I'm talking about stages 3, not even early stage 3. We're talking about stage 3C and above. What they do now in so many Western nations, like in the United Kingdom, what they do, if all the general practitioners are told, and there is a nice guideline, it's a very good guideline telling the primary physicians, if you have any woman at all presenting with bloating, abdominal swelling, assume it's ovarian cancer until proven otherwise. Do a pelvic ultrasound scan and request for CA125 level. And those are very, very simple tests that you can do. And if they are abnormal, refer them straight to the consultant so that they can be seen within 2 weeks.
That's good to know. So for audiences there, all our audience, both males and females, for the males, the females in your life, if they're experiencing that symptom, bloating, abdominal distension, do not, weight gain, do not overlook, right? This is just, okay, I'm getting old. There is need to just, present yourself to your primary care and let them do what they should do, because there's already protocol and policies down in place for the right, for the way forward, if I should use that word. Okay. So the typical, unfortunately, this currently the trend is the diagnosis is made late at relatively late at stage 3. Now, if you remember, I did once mention in medicine generally, as we go, when it comes to diagnosis of cancers, as those number increases, the prognosis becomes worse. It's a worst case. We always want to present ourselves early. So if there's a case of cancer, the best will be when it is even before it gets to stage 1. That's the essence of screening. However, if it's caught earlier, then there's a better chance. So that being said, what now that the diagnosis is made, how now do you attend to this? How do you is it surgery? What is the management generally? How do we treat ovarian cancer?
It is a combination of different treatment modalities because the majority of cases of ovarian cancer that we see is at a later stage. So it's a combination of chemotherapy and surgery. I think we tend to do primary surgery, and then followed by chemotherapy, or in certain situations where you find that disease is so widespread that you cannot guarantee you will be able to remove all of the cancer at the time of surgery, then you have to give them chemotherapy first and then go on to surgery. Now, I think over the years, what has actually changed, chemotherapy is more or less the same. What has changed over the last 15 to 20 years is the approach to surgery. Ovarian cancer surgery is not just a pelvic surgery. Unfortunately, ovarian cancer is the type of cancer that spreads throughout the whole of the lining of the abdomen. So when you're doing surgery for ovarian cancer, it's a combination of upper, mid, and lower abdominal, as well as pelvic surgery. Typically, when you're doing, surgeons have to be properly trained, not only to do pelvic surgery. In fact, if you come to my operating room when I'm doing ovarian cancer surgery, you would never, ever think that I'm a gynecologist. You would think I'm a general surgeon, because you start operating from the upper abdomen, because the aim is to remove all of the cancer. And typically, ovarian cancer surgery would take about 6 to 10 or even 12 hours to resect all of the cancer, because the evidence is very clear that if you can remove all visible disease at the time of surgery, these women, they tend to live longer rather than if you leave any cancer behind.
Okay, that is that's very interesting to note. So it's not just a surgery involving the pelvic area, like you said. There is that extensive involvement of the upper abdomen in order to take out as much, or take out, because it's a condition that, especially, I'm guessing, especially at the time of diagnosis, that there's a lot of seeding that has occurred, distant, if I should use metastasis at this point. So it's not just confined now to the ovaries, right? And so there's a need for extensive. Is that?
You're absolutely right, because there's a lining inside the abdomen we call the peritoneum, and then you have the big fatal pad in the upper abdomen called the omentum, and then you also have the lining covering the diaphragm and all over the whole of the abdomen. So the aim is to be able to have access to the whole of the abdomen, to resect all of the peritoneum. If they are affected, you usually will have, by the time ovarian cancer get to stage 3 and 3C, you have these seedlings, like you rightly mentioned, all over the abdomen. In fact, doing an operation to remove the uterus and the ovaries is the simplest of ovarian cancer surgery. Doing that operation will only take about 1 hour. So you'll probably spend about 6-7 hours doing other operations, trying to remove all of the visible cancer that you can see in the whole of the abdomen and pelvis.
Okay, so now a reminder to our viewers, I didn't mention this earlier. So please, we would love to hear your questions. I'm sure we have learned so much so far, and there'll be questions lingering in your minds. And this is the opportunity, because in front of you is a specialist. He's the authority of ovarian cancer. We're talking about not just not an obstetrician and gynecologist, but also a gynecological oncologist, right? So there's a specialty and another specialty, two main punching specialties here. So any question regarding, it might be you personally or someone you know, and it might be just just being wanting to have that information in general. Okay. Well, we are having questions here. oops, can I see those questions? Just excuse me. Okay. Is there a link between, very good question, is there a link between cervical cancer and ovarian cancer? So that's the first question we have here. So Dr. Abu, over to you. Is there a link between cervical cancer and ovarian cancer?
No, there's no link at all between cervical cancer and ovarian cancer. Cervical cancer is caused by a type of virus we call human papillomavirus, and that is not known to cause ovarian cancer. So they're totally different. Cervical cancer is not known to be hereditable. So ovarian cancer, on the other hand, could be a hereditable disease. But like I said at the beginning of our talk, the majority of cases of ovarian cancers that we come across are not hereditable disease, they're just sporadic.
Yeah, as you mentioned that, can you also just talk about that link between the ovarian cancer and the breast cancer, the BRCA variant type? Is there a link between the BRCA1 and 2 with the ovarian cancer?
Yes, that's correct. There is definitely a link between the BRCA1 and the BRCA2 genes. If you have the BRCA mutation gene, then you're more susceptible to developing ovarian cancer and breast cancer. And these are the women that we would normally advise. Now, once they have completed their families, they should consider having prophylactic surgery to reduce the risk of them developing either breast or ovarian cancer.
So that is that's a very important note. So the variants, BRCA is a variant of BRCA1, 2, a variant of breast cancer. And what Dr. Abu is telling us is there's that advice given for prophylactic surgery. That's, even though it hasn't occurred, just something that you might want to entertain of doing a surgery just to reduce the chances of coming out with ovarian cancer, because there is found to be a link between these cancers. Now, not all breast cancers are BRCA positive, right, Dr. Abu?
You're correct. I'm not a breast cancer surgeon, but yes, you're right.
So there's a case. It's not all cases we're talking about breast cancers. We go to the clinic and there are various tests that will confirm this is BRCA positive or negative. And for the positive, there's found to be a link between that and ovarian cancer. So those are the class we are talking about here. Okay, so the next question here is there a link between staying as a virgin / asexual with ovarian cancer? Dr. Jafar, link between staying ovarian cancer?
No, I wouldn't say there is, but if you ask me if the person wants to remain a virgin all their life and not have children, then there is a slightly increased risk of developing ovarian cancer, because women who have not had children, they are at a higher risk of developing ovarian cancer compared to women who have had children. And that's partly because those who have had children, they had a period of their life when they are not ovulating. Okay, and the same way, for instance, the combined, I know this is a slight digression, the combined oral contraceptive pill, when you take it for several years, it means that you're not ovulating and you're not menstruating every month. So that also helps to reduce the risk of developing ovarian cancer.
I see a lot of people are interested in that concept because a question just popped up. Please, can you explain again the area of prolonged menses in ovarian cancer? So I hope the person that posted that question, you did catch it this time. Basically, Dr. Abu is mentioning that I think, and you did mention this earlier in the discussion, that during that when the ovary is being stimulated for every release of eggs, and when that happens repeatedly every month, that is the predisposing risk. So for people that start menses early to a late onset of menopause, there's that long reproductive life, and every month they are ovulating. I think that ovulation is the stimulation that is now predisposing to the ovarian cancer, right?
That's correct.
So you think about it, when you're taking contraceptive, you're no longer ovulating. When you're pregnant, you're no longer ovulating.
Or when you're breastfeeding as well.
Or you're breastfeeding. So I hope that answers that question. I see a lot of people interested in that. Okay, another question here. If women remain single and do not conceive, does this increase their risk? Well, again, I think that's that explanation should answer that, Dr. Abu.
That's correct.
Yeah. So I hope you got that point now. Everything is related. The more you're not ovulating, it's a risk factor. It will not cause it. It's just something that's a risk.
Correct.
Yeah.
I think that's a very good point to make. It's a risk factor. It doesn't cause it.
Yeah. So people don't get worried that, oh, I've been ovulating all this, and no. It's one of those risks. There are other risks. Dr. Abu talked about weight gain, smoking. So these are all things, and then genetics too, hereditary. Okay, you talked about obesity. If women lose weight, does that reduce their risk, Dr. Abu?
I would have thought so, because if obesity is a cause of is one of the predisposing factors to developing ovarian cancer, I think it does make sense that weight loss will reduce that risk. And don't forget that when you lose weight as well, there are so many other health benefits. It's not enough to just lose weight. If you're a smoker, you want to stop smoking. And we all know that smoking causes so many, cancers.
Yep. Yes. So that which is under our control, which is weight gain, smoking, that which is under control, I believe we can address. There are certain things that is not under our control. We don't control when we start having menses or when we stop having menses, or Dr.
Absolutely.
So that which we can control as regarding the risk, then of course we can try to address. Question, you talked about the fact that ovarian cancer affects other parts, including the abdomen. How many cases do you see coming with more than one cancer, but originating from the ovaries? I think he's talking about metastasis here.
Yeah, if you're talking about metastases, I would say that about 3/4 of the cases that we see are advanced cases of ovarian cancer. You're talking of, again, it takes me back to the percentage of, 70-75% of cases are advanced. Stage 3C essentially means that you have disease that has spread throughout the whole of the abdomen. Stage 4 means that the disease has gone either into the chest or has actually gone into the liver. But even with advanced stage disease like this, we don't give up. We still treat them. I have had women who had advanced stage cancer that I treated over 5 years, 10 years ago, who are still alive. So we now refer to ovarian cancer as a chronic disease because there are ongoing trials looking at targeted therapies, immunotherapies, and all sorts of treatments that we can use to prolong the life of these women, even when the cancer comes back. A long time ago, we used to say, once the cancer comes back, you don't operate, it's just chemo. That's not true. I was one of the principal investigators on a trial that was multinational, the desktop trial, looking at patients who have a recurrent ovarian cancer. So there are a selected group of women who have recurrent ovarian cancer that you can actually go back and operate, and you may be able to resect all of the cancer.
Hmm. So talking about the recurrency, how prevalent is this when after you've done the surgery, be it a stage 3 or 4, and it's said to be successful? How common is the recurrence, despite having the surgery?
Unfortunately, it is common.
Mm.
And we do extensive surgery, and we treat with chemotherapy and targeted therapies. What we're actually trying to do is to prolong what you call disease-free survivor period. So we want to prolong that time before the cancer comes back. And when the cancer comes back, we can still either operate or give the chemotherapy again. So we normally talk about 5-year survivor. The overall 5-year survivor for ovarian cancer, even in the most developed world, is in the region of about 40-45%.
Hmm. Wow. Wow. Okay. Okay. Now I do noted to our audience that you've had 30 years of experience in these specialties: obstetrics, gynecology, gynecological oncology. So my question now is, over these years, have you seen changes in the management of ovarian cancer? Maybe the approach to surgery, and what are the outcomes compared to current now, 2023 versus 30 years ago, 1993? Is it 2030?
That's going really way back.
Yeah. So what are those? Is it the same approach, or is there, like, having done research? Okay, this is a better this is a better approach with a better outcome. What do you say to that?
I think the main change has been in surgery, the surgical approach to ovarian cancer. I remember when I was a medical student, or even a very junior doctor, just eventually coming to GYN oncology. When I was training, we used to have GYN oncology surgeons of those days. They would do a midline laparotomy, do a simple total abdominal hysterectomy, and remove the omentum, and that was the end. But that's changed now. Okay, that's totally changed. We now combine surgeons who operate on ovarian cancer. Not every GYN oncologist can actually do ovarian cancer surgery. You have to have extra training in ovarian cancer surgery to carry it out effectively. So there have been a dramatic change in that. And then, of course, over the years, we have also had some research looking into targeted therapy. For instance, if you have women who have the BRCA mutation and they develop ovarian cancer, there is a targeted therapy that you can actually give them that will prolong their life and prolong the disease-free survivor. So things have really moved on. And that was why I was telling you earlier, that we now treat ovarian cancer more like a chronic disease.
Mm, mm. Very interesting to note there. So there you have the various approaches, the changes in the approach to the treatment of ovarian cancer via surgery. A question I'll ask, another question. We talked about the primary cancer, which is the ovarian cancer metastasizing or seeding within the pelvic slash peritoneal cavity. How about a case where the ovary is secondary? So you have a primary diagnosis or a primary cancer metastasizing now to the ovaries. Is it the same presentation? And in this case, can you just talk about how this is managed?
Yeah, that's a totally different kind of presentation. You can have cancer from other parts of the body, typically the GI tract. We're talking about the stomach or the large or small bowel metastasizing to the ovary, and that can cause a large ovarian mass. We refer to that as Krukenberg tumor. And what we tend to do with those cases is do an operation to remove the ovarian mass. It's mainly palliative kind of surgery if the ovarian mass is causing pressure symptoms.
Okay, so we just talked about the cases of metastasis, a cancer from elsewhere metastasizing to the ovaries, right? And the approach, and Dr. Abu has just told us that this is more like addressing the symptom palliatively. That's what, not the symptom caused by the effect of the ovary, right? Or the effect on the ovary, if I should use that word. And there are different cancers, such as from the stomach, which you call Krukenberg, that could actually go to the ovaries. So there's also the need to confirm, yeah, it's affecting the ovaries, but there's a difference between a primary cancer and a cancer metastasizing to that organ. In this case, a primary in the stomach metastasizing to the ovaries. Okay.
That's correct.
Yes. So you did mention in talking about one of those changes in the management currently. We mentioned, for instance, the targeted therapy when there's BRCA involvement. Are there ongoing researches now in the area of management of ovarian cancer that probably you're anticipating because of the hope that projecting to the future, 20, 30 years time, this can successfully address, and we don't have what we have right now, which is still a very much high prevalence of deaths or mortality associated with ovarian cancer? Are there researches that are ongoing right now that is going to address a better management, probably earlier diagnosis, and treatment of ovarian cancer?
Now, I spoke about the big trial in the UK called the UKC Talks. What they actually did was to collect lots and lots of samples from the thousands and thousands of women who were very, very kind enough to go into the trial. So they have a huge bank of either tissues or blood samples that there are always trials that are going on. And even when it comes to treatment, there are also trials going on all the time. There was even a trial with results that came out recently called the Paolo 1 trial that was looking at this targeted therapy combined with another medicine called Avastin to show that you can have a much better survivor. You're talking about, I told you before, 5-year survivor of about 40 to 45%. But with this trial, they were actually able to achieve a 5-year survivor of about 66%, which is really, really remarkable. So there are always trials going on ovarian cancer.
That's excellent. So there is hope. As always, the world of medicine is never stagnant. There is ongoing research. So even though there might be breakthrough, in future, there could even be more, that's what it's the beauty about ongoing research is, the scientists and every other person in the medical community, the consultants. Okay, so the last question I'll ask, if no other question, the last question I'll ask, Dr. Albo, I know you yourself, you are very much invested and involved in all the researches, and we talked about the annual, the Nottingham laparoscopic course, the training course you did establish. So are there other things, in the radar that you're involved in, with respect to ovarian cancer, or other things, advancing, like we said, these, causes? And what do you look forward to right now, in the advancement of the management of ovarian cancer? And that would be my final question.
I mean, like, I was in the UK for a very long time, and I was a consultant in one of the big teaching hospitals there. And several years ago, apart from this laparoscopic and robotic surgery, I also was the one who introduced this extensive ovarian cancer surgery. This is about 15 years ago. And then moving from the UK to the UAE, where I am now working, I have come to realize that the type of surgery that we probably take for granted in the UK is not readily available here. So I am on a mission here to spread the word so that you don't have women with ovarian cancer ending up in the wrong hands. I think that is my number one goal here, because like we said at the beginning, the mortality from ovarian cancer is so horrible. Ovarian cancer is one cancer that you will not wish on your worst enemy. And one opportunity you may have is actually having the right and effective and timely surgical treatment. That first operation that you have is very important. So if you fall in the wrong hand and you have the wrong operation, that could affect how long you're going to live. And if you are lucky enough to fall into the right hand of a good surgeon who is well trained and experienced at doing ovarian cancer surgery, that could well determine how long you're going to live as well.
Thank you so much. I know I did mention that was the last question, but since you really have emphasized this, I'm going to ask you, who is the right person then that will do the surgery? Who do we look up to really to attend when we have this, if this issue arises? Who is the best person to approach the surgery?
There's no doubt there was a trial that was done several years ago, really looking at ovarian cancer and other types of gynecological cancer. Any woman that has ovarian cancer or suspects they may have ovarian cancer, of course, you see your primary care physician first, who should refer you straight to a GYN oncologist, not a general surgeon, not a benign gynecologist, but it has to be a gynecologist who has the expertise of GYN oncology. So, and to be fully trained as a GYN oncology surgeon, you complete your primary training in obstetrics and gynecology, and then you spend extra 3 or 4 years just training purely on GYN oncology. So the GYN oncologist is the right person to be doing ovarian cancer surgery.
Thank you so much, Dr. Abu Jafar. So for our viewers, that last point he just made, the best person that approaches this is the obstetrician, the gynecological oncologist. You know, in medicine, there's different, I think we've emphasized this a lot in this our webinar. You have different specialties. There's the primary that really can deal with any, you know, that is very broad knowledge. And pretty much every doctor, surgeon is broad knowledge, but the primary doctor, primary care, pretty much, you know, is that like this word primary, first source, because they are very knowledgeable of everything. However, when it comes to specialty, when there's a need to address a specific issue or condition, then they now channel you to that specialist, right? Dr. Abu, yes, he has he is an obstetrician and gynecologist. That's primarily. However, he's specialized in oncology. Oncology is cancer. People specializing in the treatments and everything that has to do with cancer. So he is the gynecological oncologist, meaning when it comes to female reproductive area, is the best person to approach when there's a cancer involving any of the female reproductive area. And he tells us now, advises us, basically, those are the best people, specialists that will really attend because they have the extensive knowledge when it comes to these areas, right? So I can't thank you enough, Dr. Abu, for honoring this invite and discussing.
It's been a pleasure talking to you.
Yeah, there's been so many questions. Thank you so much for the education. Thank you, our audience, for also honoring this invite. Now we have our next webinar is for the 29th of June, and this is on fibroids, another very, very important topic when it comes to the female reproductive health. I personally know a lot of people, females, especially the Black population, somehow, you know, affected by this condition. So I'm sure you guys wouldn't want to miss it. This is on the 29th, so stay tuned for that. So thank you so much. We have a lot of thanks, Dr. Abu, to you. A lot of people expressing their gratitude for the talk, the enlightenment, and I'm so happy and that everyone has really found so much of meaning in this, right? So I look forward to seeing you all next time. Thank you so much, Dr. Abu. Thank you for Digital Medical City for providing us with another great consultants and specialists. And I look forward to seeing you all next time, either Dr. Chichi or I, or some other persons will come and host the program, the webinar. Otherwise, you all have a wonderful morning, afternoon, evening. Over here in the US, it's afternoon. As always, we like to say good night, good evening, good afternoon. So take care. Thank you, Dr. Abu, again.
Bye. Thank you.
Bye. Okay, then see you guys next time. Bye-bye.